Welcome to a brand new episode of Seize the Moment podcast. And today we have a very special guest. We have Eram Alam. She's a historian of medicine and associate professor in the Department of the History of Science at Harvard University. Her research explores the intersections of race, migration, and healthcare with a focus on how global labor flows have shaped American medicine. And her new book, available October 14th, is called The Care of Foreigners: How Immigrant Physicians Changed U.S. Healthcare. Welcome. It's a pleasure to have you on.
It's a pleasure to be on and to share this space with you and to talk about my work. Thank you.
Absolutely. And then so in her book, Eram wrote that the United States spends far more per capita on healthcare than any other country, obscures its long-term underinvestment in the healthcare labor force. Without a concerted reimagining of fundamental structures, foreign physicians will likely be asked once again to provide care in America's shortage area communities. And they will respond, shouldering this care work as they have in the past. For the last 60 years, their essential presence has allowed organized medicine and the United States government to prioritize profits and special interests over the health of millions of poor, marginalized people, relegating them to debilitated life or premature death. By beginning with the Cold War and the Hart-Celler Act of 1965, I emphasized the geopolitical stakes and neo-colonial conditions that marked the beginning of this migratory regime, which persists into the present. So phenomenal writing. And so as we're kind of going through this, I feel like it's such an interesting and sort of underserved, obviously here, no pun intended, kind of topic here, because like we don't often really think about sort of healthcare from I guess, a foreign perspective, or just what it's like when we're thinking about kind of taking away resources from other countries. So I mean, there's just so much here to get into. But so can you actually just first, I want to kind of start this in a sort of simple way. Can you actually tell us what got you interested in this topic in the first place? Like, how did you even kind of come to find out about it? Because again, it's something that like most of us don't even really think about on a day to day.
Mm.
It's funny. It's my whole life. So I am an Indian woman, first generation immigrant. My parents came in the 1970s. And every time that I would go to the doctor, I would always get asked if I was a physician.
Hmm.
And then I would say, no, I'm not. And I would say I'm a historian. And then you get this quizzical look like, what? Who actually does that? And then they'd ask, oh, are your parents doctors then? And
Mm,
I'd say, no, actually, my parents aren't doctors either. And so, like, even
Mm.
just that kind of, it sits in the background of these things. And then I entered into the history of medicine and started my PhD there. And I started reading all of these big books. I mean, like this big books about
mm,
the history of
Wow.
US healthcare.
Yeah.
And there was one page about immigrant physicians, or at that time they were called foreign medical graduates. So you'll hear me use that term. It's not meant to be derogatory in any ways, just the historical term that was used for the majority of this migration. And so I put these two things together of like, why do people always think that I'm a physician? And what is going on here where these people are not being talked about? There seems to be this huge gap in all of the scholarship about the labor force. And so that kind of just piqued my interest a little bit of, what's happening here, that this is so common on the one hand, that offhand, any nurse, any doctor is like, oh, you must be a doctor. Yet it's not common enough for it to receive the kind of academic or scholarly attention.
Mm.
mm.
I find also the title of the book very interesting. I wonder if this was meant purposefully, but The Care of Foreigners, is this meant to be sort of a double-edged kind of title? Like, on one level, of course, on the surface, I think of the care from the foreigners, right, from the doctors. But then from another level, as I read the book, I'm thinking, oh, okay, this is also how they were treated, right? Is that right?
That's absolutely right. Thank you so much for,
Yeah.
I love titles. I was saying that, I got the bug for titles from
Yeah.
from my yearbook editor days in high school. They've stayed with me since then. But yeah, that's exactly right. Is we need to really be intentional about how we're thinking about this labor force, or any immigrant in that matter. And that it's not just the labor that they're providing, but it's how they are also being taken care of within the context of the US, because
Mm.
both of those they affect one another. That's a feedback loop that's happening there. And I think we really have to pay attention to both of those aspects.
Oh.
And something I'm curious about, just for our audience, what is the Hart-Celler Act? Yeah.
Yeah, so 1965, there's this moment in the United States where US is the premier superpower,
Hmm.
and they start to think about immigration as being this really important thing that needs to have some reform. Because prior to Hart-Celler, which is this 1965 act, the major comprehensive act that was on the books was this 1924 Immigration Act. So the 24 Act had a couple of components. One was the national origins, which meant that if you were from Southern Europe or Eastern Europe, there was a very limited quota of who could actually come to the United States. And then it had another component where it was basically it was an Asian exclusion act. So anybody from
Mm.
any Asian country was disallowed from entry and citizenship in the United States. So that's the 24 Act that's on the board. And that's actually when the US Border Patrol also became a thing, enacted. Then you have 1965, where the US has a very different position in the world. 24, kind of this isolationist, orientation. 65, they're like, how can we tell all of these new countries that are entering into, we're in the Cold War, we want them to join the democratic fold. We don't want them to go for the Russian sphere of influence.
Hmm.
So how are we going to say, oh, be our friends, but you can't physically come to our geographic border?
Mm-hmm.
Right.
So that really provided this kind of geopolitical impetus where these lawmakers were like, what's going to happen is that places like India, places like Pakistan, they're all just going to go towards the Russian sphere of influence. They're
Mm-hmm.
not going to want to come into, the US's orbit. So immigration becomes this really important point of having to remedy that. So the United States can say, hey, look, capitalism, awesome, open, democracy, awesome, open,
Mm.
come join us. And even just prior to that, maybe 10 years before, that's when Fulbright as a thing started, where it was like educational exchange became this really important thing for that exact reason. And so this just opened it up in a more comprehensive way where they realized, okay, we need to not tell all of Asia, which is huge, that they can't actually enter into the United States. So huge geopolitical motivation there. And then at the same time, so you
Mm-hmm.
have 1965, July of 1965, Medicare and Medicaid passed in the United States. So Medicare, just to, reiterate, is a post 65 and older, you get insurance. Medicaid is those people who are low income and disabled can enter into the US government helps with insuring them. So you have overnight at least 20 million people that have federally funded insurance and that are entering into the healthcare marketplace.
Hmm.
October, which is when Hart-Celler is passed, is there's a special provision for people that could come into this country if there was a shortage of labor.
Right.
So it turns out when you have all of a sudden 20 million people, in addition to just a lot of general forces of increased medical demand that are happening at that time, there are a lot of babies being born, post-war babies. Babies need a lot more health care than, people in their teens, people in their 20s, etc.
Hmm.
So you have these two things that happen is domestically, there's this huge need for physicians and other healthcare laborers at this time. And then geopolitically, there's this need to open up the country. So Hart-Celler becomes this really interesting piece of legislation where they wrote in there that when there's a shortage, you can have expedite entry of professionals that the United States needs. And it just so happens that many, many of those professionals came from those very countries that the United States was also trying to develop these diplomatic relations with at that time.
Mm.
Wow, great. Wow, and there's so many directions that we can go with here. I'm going to try. We're going to try our best, I think, to cover all of them. So the first thing that comes to mind is sort of this understanding of a manufactured crisis, right? Which you significantly speak on and touch on. So when a lot of times, I think when us as like let's say the average viewer or whatnot, when we watch television, CNN or whatever, we're kind of wondering like how real is a lot of this stuff, because this country is obviously so big. I mean, it's kind of hard to know what is and isn't an actual crisis. So when we think of a manufactured manufactured crisis, we sort of think of people kind of, so this is what kind of makes it a little bit tricky. We think of people who kind of are deliberately doing it, which is a lot of times why people, when you go into the more kind of conspiracy fringes, they're thinking is like, well, they kind of know what they're doing, right? Which I'm sure you would agree a lot of times it's not really that deliberate. But the interesting thing is, and the point that you make is that, like, fundamentally, it's not necessarily just a crisis. It's not just some kind of random thing that happened. It's this thing that's sort of based on policies, based on structure that we talk about. And so that's what I want to kind of get into. So when you say that there's a kind of manufactured health crisis that obviously in this particular case, foreign born, let's say physicians were kind of brought in to cure, for lack of a better term here, how would we define that manufactured crisis and what makes it so?
Yeah, I mean, if I were to ask anybody, like, hey, what's a shortage? Okay, you say, well, not enough. But how do you decide that? Not enough based on geographic location, based on skill set. It's actually quite a complicated thing that I think we reduce to very simple, like, oh, there's not enough. But
Mm,
when you get down to the nitty-gritty of thinking through what that means, especially on the question of distribution of labor, I'm in Boston.
mm,
There are very few shortages of physicians here because there's a huge concentration of health centers, of academic medical centers, of
Mhm.
hospitals. But you go a little bit, you can go to rural Connecticut and rural Massachusetts, and there's a shortage there. And so, I think we have to be much more precise about what this is and why it is the case. So, yeah, I do make the argument that these ideas of shortage and crisis, even crisis. So you say crisis is an emergency, but we've been calling this thing a crisis for the last 60 years. And so, like, at what point does the emergency stop being an emergency? Like, what
Right.
is the time frame? What is the temporality of an emergency if you just keep doing the same thing over and over and over again? And so this is why I make the argument about this kind of manufactured crisis, because there are ways to intervene in this situation so that it doesn't, the system shifts and we don't keep saying, oh, we're in a shortage, oh, we're in a crisis. But there isn't the political will to actually make that happen. And in fact, exactly like you said, like historically, these things, it's not as if there's some kind of conniving conspiracy theory crew that is deciding, all right, let's just keep this going. But maybe a little bit, maybe there are some kinds of historical decisions that have been made for many years before 1965 that have led to this place that you could have predicted the US healthcare system was going to be at this point. And a lot of those have to do with, really the American Medical Association, which really gained a lot of power in the early part of the 20th century and wanting to cohere into a profession. And before that, medicine wasn't like that. People could get training in all sorts of ways. People could get diplomas in all sorts of ways. You could claim, to be a healer. There were homeopaths, people were doing water cures. All of these things
Mhm.
existed alongside one another. And then the medical profession, in the way that we know it now, came in and was like, we need to regulate this a little bit. Things are getting a little bit too haphazard. Too many people are claiming to have this kind of knowledge and expertise that we want to have and jurisdiction over. And so they made some moves about that. They made licensing moves. They made things that were much stronger in terms of training and recruitment. And what happened was they kind of closed the profession. So they didn't really let women in. They didn't really let minorities in. And you pretty much had to be wealthy in order to access medical school. And so that just shrinks your whole population of who can be a physician. And there just weren't as many positions available. If you look at the data, in the first 50 years of the US, the number of physicians did not grow with the population at all. And there are many points where interventions could have been made to change that, but they weren't for a lot of political reasons. And so then you reach this 1965 moment where what are you going to do? Because it takes a lot longer to grow a homegrown physician. You need to make sure they have proper STEM education in high school, that they do an undergraduate degree, that they're able to afford medical school, that they're able to do a residency. I mean, this is a 20, 30-year project. But if you just import a physician labor force, that's a couple month project. So it's a huge differential where you can get somebody to actually work and be providing care. And so then this became this kind of stopgap expedient solution. And it continues to be the case when all of those other things are still points of intervention that can grow the labor force today that have not been properly, attended to. And so we have the situation where, like I say, yet again, immigrant physicians, we call it a crisis. COVID, of course, 100% was a crisis. Who was called to provide the care during that time? All immigration was closed, except for immigrant physicians could come to this country to provide care.
Ooh, so I want to ask, is because I just want to follow up on this quickly. Okay. Okay. So I want to ask a really cynical question, and please, Aram, you could tell me I'm completely wrong. I hope I'm completely wrong. So would you say that for, maybe this is again simplistic, and I'm so open to being wrong. Is it possible then, or is this what happened, is that instead of sort of opening up the field to sort of more people, more sort of citizens here in this country, it's more as though the kind of the thinking, this foundational thinking was, well, if we let in a few foreign-born people, the idea is that we could kind of segregate them and keep them there. So we're not opposed necessarily to adding, let's say, extra physicians, as long as we can kind of corral and control them and sort of maintain some sense of, let's say, distance or, again, segregation, right? As opposed to sort of opening up licensure, let's say, restrictions, as opposed to kind of opening up the field and saying, well, we're going to kind of let more people in more broadly, because then the idea would be, obviously, then they have more liberty to move around. Whereas if they're a little bit more foreign-born, I mean, the idea is like, well, your place is over there.
Yeah, and I think what happens, I think that's right, because when it's tied to your visa and your immigration status, there are certain stipulations for how you can move, where you can move, what state licensures are actually willing to accept you. So I think that you're completely right in being cynical, because I think this is what happens is you get this hierarchy where US trained physicians are working in the elite medical institutions, generally in big cities, and the places that are under-resourced also in big cities. I come from Chicago. Cook County is such a huge, public hospital where 60 or more percent of the physicians are immigrant physicians and have historically been. So it's not just in rural towns, but in especially in rural towns, and that where people just don't want to go. So what do? Well, you create these kinds of visa probationary structures where it says you can come in, but you have to work for 3 to 5 years in these underserved, what's called health profession shortage areas. And after you're done doing that, after you've proven yourself, essentially, then you can try to move around and go someplace else. So I think you're right. I mean, it creates this system where people are sort of locked into a certain place and a certain route. And over time, often they're able to find their way out of that route. But what happens to the communities? You so kindly quoted me at the beginning, but what happens to those communities that, once again, they will have a vacancy for the physician, because even the immigrant physician now is coming to Boston metropolis to work
Sure.
and going there. And so you end up having this gap again, over and over and over. And then this is what made me think, like, how is this a crisis when I could have predicted this?
Hmm.
I have an opinion question actually for you. So I guess I'll preface this a little bit with a story. So my best friend, his mother is Bengali, right? And she was a doctor in Bangladesh. And when she came here, of course, she could not practice immediately. She still had to attend school here and kind of, for lack of a better way to frame this, become a doctor officially here, right? What is your opinion on that? If somebody's already a doctor overseas, has proven themselves, has their own degree, of course, yes, it's from another country. Do you think that maybe they should just be allowed to practice as soon as they come to this country? Or what? Yeah, what do you think about that? Yeah.
Yeah, no, I have a lot of opinions on this. So, in this since 2023, I think it's 17 at this point, states have either passed or proposed some kind of legislation that does exactly that. So that it allows people who have medical degrees and some training in their country of origin to come and instead of starting all over again in the
Hmm.
United States, to recognize the skills that they bring and the knowledge that they bring and to allow them this fast track entry into the labor force. And so it's very much an ongoing thing. During COVID, in New Jersey and New York, which were the epicenters of the beginnings of the pandemic,
Hmm.
um, there was this temporary licensure program that went into effect for about 18 months, where people who were physicians in another country but didn't have their licensure in the United States, didn't have the proper paperwork, could still get a temporary license to go and work in nursing homes where there was huge shortage, in all of the under-resourced hospitals. And so you see people recognizing that there is such an abundance and wealth of knowledge that people bring, even if they don't have the, the exact paperwork. And so should you just let that knowledge
Hmm.
sit there and not get used when you have a shortage or when you have a crisis? The flip side of that is people say, well, we can't trust what people learned in other countries.
I'm
And so
skeptical of that. Yeah.
I'm totally skeptical of that. I mean, especially because the majority of people come from post-colonial states, which have a history of it's Western biomedicine. In India, that's completely what's taught. In Bangladesh, in Pakistan, the Philippines was colonized by the US. These are the places that have the highest numbers of physicians that come to the United States, or they go to the UK, or they go to Canada. And all of these systems, it's not as if this is some kind of other foreign system that's being taught there. But that's what the argument is always made as well. We can't control for what these people know and how they know what they know. It's like,
Mm.
well, can you really control for that in the US?
That's totally true. That is true. I suppose that, yeah, also after a doctor gets their license, how aware are we of how often? I mean, by the way, this is a little bit of a cynical thought and not to be entertained completely, but you could make an argument that if let's say somebody got their license, they practice, but how often do we know that that doctor is, let's say, keeping up with, let's say, not necessarily advances, but even like kind of refreshing on the things that they
Right.
were taught
Up to
medically,
date on research
up to
even.
date on,
Yeah.
let's say, research
Yeah.
as well. Um, so that might help your argument as far as, how can we also necessarily trust, the people here? Yeah.
And I think it also just begs the question of what does a physician, what, I think we have to really think about what do they actually, or any healthcare provider,
Mhm.
what do you need to know? Sometimes you don't actually need the most cutting edge surgical technique of, you loop this way and you can figure this out.
Right.
The largest shortage is in basic healthcare. So it's in family medicine, it's in pediatrics, it's in internal medicine. Those are, and not to, diminish kind of the complexities of what all of those things are, but those are the kinds of frontline, really kind of generalist care.
Hmm.
So they often will already have that base of knowledge. They might not have the most advanced, surgical flip technique or something like that, but to understand, okay, maybe I need to send you to that person who has that specialist degree, but they can be those first responders to these kinds of situations. So before they get to a place of needing emergent, urgent care and surgery, I think that is another thing to really figure out and think about for the United States is like, how do we, instead of making sure we have 3 million specialists who can do the most advanced surgeries,
Mm.
have people who can actually just do the basic care so that, when you have a cold, when you have migraines, when you have, those kind of day-to-day things,
Hmm.
so they don't lead to the place of needing those advanced surgeries. In the US, we really think about treatment, but what about prevention? And I think
Right.
all of these physicians are, especially in those specialties, I mean, that's what they're really concerned with.
Mm.
Yeah, and then so Eram, in your book, you also give the perfect example of what you guys were just discussing. So you mentioned Naya and Seth. I think that's how you probably pronounce the name. Can you tell us their story?
Yeah, absolutely. So this was a physician who in the 1960s was trained in India, was working in India for many years, had a practice set up there for 7 years. And then he started to notice that more and more of the people that were around him, huge cohorts of physicians, were leaving India and going to work in the UK or in the US. And so he decided, this might be an interesting thing for me to consider as well. And back in the day, US embassies had these information offices spread all throughout overseas countries. And in there, they had medical journals, and he would say he'd go to the libraries at these US information agencies because they were also propaganda, soft propaganda machines. And so he'd go and he'd read these things, and he was like, I was very intrigued by what was happening in the United States, and hospitals that needed physicians would advertise in these journals as well. And so they said, okay, if you can pass this exam that physicians need to take in order to come, we can help you with all of the other logistics and things. And so he had, wife and he had a kid, and he thought maybe this is the time to make the move, that I'm feeling a little bit stagnant in my career here. I'm not able to make as much money as I want. And so he went and he, decided to take this exam, passed the exam, and within a month to 2 months was in the United States, ready to be a resident in these post-industrial cities in Ohio. And I mean, these physicians were everywhere in Alabama and Ohio and all of these places that were really struggling, especially during that period of time of deindustrialization. And, populations are moving out, healthcare infrastructure is really not there. So then who comes? So he came to the United States with a cohort of 10 other immigrant physicians from India, Pakistan, and the Philippines,
Mhm.
and started, just working there and providing care in those communities.
Mm.
Wow. Yeah, what makes all of this so frustrating is if you think about it just from the perspective of the Cold War at the time and just capitalism and communism. I mean, so I know, I guess it depends on sort of what side you're on, but it's interesting because on both sides you kind of have this same sort of innate sort of racism, despite the kind of pedagogy or the sort of ideology. Because on the one hand, with communism, I mean, you have this sense of this universal worker, which I mean, for anybody who's ever been to the Soviet Union knows that that's kind of bullshit. And then you also have when you look at the capitalistic states, like obviously the United States, you have this sense of sort of exploitation and severe exploitation. So, I mean, let me see what the question here could be. So, what are normally then the experiences from your research from for people who are sort of for who are foreign born physicians? What is it usually like for both for them and for the people that they treat? So what happens when somebody is brought into the community, maybe even unbeknownst to some of the population, and they are trying to come there, they're there essentially to help and to serve these needs. Would you say that there's more so a sense of gratitude from the population, from the locals, or is it more so a sense of maybe perceived threat or a sense of kind of maybe not necessarily indignation or resentment, but a sense at least of fear and speculation?
Yeah, I think that's a really great question. I think any foreigner is always going to elicit, especially the ways that things are constructed in the United States, elicit some kind of discomfort. So here, I'll take you back to the 1960s moment because you referenced it. So imagine what's happening within the clinical space at that time. In order for any hospital to receive federal funding, they are forced to desegregate. This was one of the most important things that the US federal government did at that time, that if you want any of these Medicare and Medicaid dollars, you cannot be a segregated facility. Okay. So you have all of a sudden Black patients, white patients in the same spaces. You have white physicians more often than not. And then you have these immigrants. You have these often, South Asian men who are entering into this space. And so this is a very, very different kind of social dynamic that's being played out in the
Mhm.
clinic. And I think that it took a lot of time. So for the physicians who came, the ones that I spoke to, they talked about how they were totally shell-shocked because again, they're coming to the United States during a time that's very politically volatile. One of the physicians that I talk about, um, he came just a week after the riots, after Martin Luther King was assassinated in Chicago. And he came to Cook County, which is located exactly within that community in the west side of Chicago. And he's like, I had no idea where I actually landed. I mean, this place is burned out. There's glass everywhere. This is not the Hollywood America that I've seen, on TV or my and talked about. So I think there was definitely an adjustment on their part of trying to understand you can't just enter to be a physician and to be an effective physician takes a lot more knowledge than just knowing how somebody's a cell works,
Hmm.
or how insulin is moving. You have to understand how people are living, where they're living, what they're eating, what they have access to, how they're moving in certain spaces, and that's a whole different kind of education. And so I think for them, there was that adjustment of really getting attuned to those kinds of dynamics. I had other physicians I talked to who went to rural Alabama and they're working in Tuscaloosa. And they've never even seen Black people in their lives before. B, often the people that are coming to the United States, they're elite as well. I want to also emphasize that. The ones that can make it to get medical education in the US and to actually be able to come to the United States within their social context, those are the elites. So they've probably never interacted with farmers before.
Hmm.
And they've never interacted with Black farmers before, and they've never been. So there's a whole different kind of education that needs to happen for them to be able to provide effective care as well. And I think it wasn't always completely accepted. There was the patients questioned their expertise. Where are you coming from? How do we know that you know anything? Um, Different patients, different kinds of questionings happen. They would often talk about white patients always saying, well, go find the real doctor because there was an assumption like, you can't be the real doctor. That's just not, you must be some kind of orderly or, random helper person. And, but then what they also talked about is that they had to strategize with each other and they had to think differently about how they're going to actually enact this clinical encounter. Because just, I mean, anytime you're sick, you're the
Hmm.
most vulnerable. You're in, the worst state ever. And you're going to this place, and it is such an intimate interaction, right? So it's like
Yeah.
you're vulnerable, you're intimate, you're, just at your worst here. So I think in some ways, what happens is that these physicians, they really understood that and they came to that with a kind of compassion, a kind of empathy, and a kind of patience that just took a lot of time and a lot of understanding that they're not going to be able to walk into a therapeutic encounter and start pushing on someone's stomach to say, hey, are you having some pain here?
Mm,
Mm.
Instead, they have to do something a little bit different. They have to take a seat. They have to take a step back. They have to talk to a person. They have to share a little bit about themselves to get some kind of, familiarity and social rapport before they enter into, let me just, start
mm,
pushing on your stomach.
Right.
Because nowadays you go to the hospital or you go to a doctor, they just show up and start
mm,
pushing on your stomach. And you're like,
Yeah.
what is going on here? So I think it is learning those kinds of soft skills that are, I mean, those are skills that have to do with being physicians, but those are also just skills that people who are on the outside always have to figure out different kinds of ways in.
Mm.
And so I think that they really thought very critically about how to do that so that they could provide the care that they wanted to their patients. And then ultimately, at the end of the day, if you're the only physician for 200 miles,
Yeah.
what is somebody going to do? So I think that on the part of patients as well, there was a kind of, yeah, well, this person is doing the thing that I need them to do. So at the end of the day, I can be racist and xenophobic, but also that's going to hurt me
Mm,
Yeah.
because this is the person with the skills and the knowledge that I need, So I don't know. I think it's certainly, we'll see what happens now, especially with this recent budget cuts and the cutting of funds, Medicare funds especially,
Yeah.
and to these hospitals where people are going to go.
Yeah, actually, it's funny that you brought that up. Well, not funny, but yeah, Medicaid cuts as well as Medicare cuts. Hospitals, at least as far as I know, or rather, medical institutions in New York, I believe there's a 13 billion dollar budget cut uh, that's going to be enacted. There's something called Essential Plan that people have in New York as well. That's going away. And the funny thing is, in terms of how people get these plans, it's based on your income and your household size and that sort of thing. What I heard from the big beautiful bill in regards to those budget cuts is that one, in order to start to qualify for Medicaid, you have to show that you're working for at least 40 hours per week. But funny enough, if you are working 40 hours per week, then you're kind of in an income bracket
Yeah, you're not going to
where
need
you might not
Medicaid.
necessarily get
Hmm.
Medicaid. And if they're taking away that essential plan, the funny thing is, first there's Medicaid, then there's those essential plans. So you're in a little bit of a higher income bracket than the people who get Medicaid, but it's still affordable. If you get rid of that, it's either free insurance or those plans that cost hundreds of dollars per month. And then also those tax credits that people enjoy, those are also getting reduced. So it's going to be a very interesting situation, at least as far as I know in New York. I think even worse in some other states, but I don't have all the facts at the moment. But yeah, it's going in an interesting direction, at least
Yeah,
during this administration. Yeah,
yeah, no, I think that that's right. And
yeah,
when we think especially about this rural healthcare, and the huge cuts that are going to happen to Medicaid there. So many of the rural hospitals, they receive funding that, so especially for immigrant physicians or for any residents, let's start there. For any resident who comes to a hospital, the US government subsidizes some of their salary. And the reason that they do that is because if in these hospitals that are working on very, very small profit margins that are poor, you need to have residents. And if they can't pay people's salaries, then people are not going to be able to come. And so I think what you're going to see is, especially rural communities, they're going to get these huge Medicaid funds that are cut. And then as a result of that, you won't have as many physicians that they're able to actually employ. So now
mm,
the work that's supposed to be spread 10 people is down to 5 people. Your wait time, if it was 6 months, is now gone to 9 months to see
mm,
this person. And so it's just going to have huge, huge negative consequences, not to mention all the stuff that you have just talked about is people are going to end up being in huge amounts of medical debt. It's like
mhm,
you have to make the decision. Do you want to go into medical debt, or what are the trade-offs that you're going to make? Is it going to be financial, or is it going to be health? Because you can't have both when you're in that kind of precarious bracket that you talked
right,
about in New York, one emergency and it's over.
yeah,
Yeah, and interestingly, I mean, you would think of, I think most people would think of when we think of America as a sort of country that provides aid. So you would think that, like, for the most part, what's happening or what should be happening is that we're essentially sending our physicians to other parts of the country rather than importing more of them, or at least there would be some sort of balance. So, but the interesting thing is now we have to deal with this other global problem where we're importing physicians, and as you mentioned in your book, we're now leaving resource sort of drained countries already with more resources trained. So I guess what is sort of the thinking there? I mean, is the United States too concerned about it? Is it thinking, well, we're sort of competitive and we're able to bring these people in, so these
Yeah.
other countries have to figure it out on their own? But like, how do we sort of perceive ourselves as a nation on a global scale, and sort of what we're doing to resources elsewhere?
Yeah, no. So it's a really good question and really important. And even back in the day, there was always this concern about brain drain. What does it mean that we are taking from these countries that we're trying to have them, we want to help them develop, right? That's the
Mhm.
language, especially of the 1960s, and want to help them develop. But at the same time, the people that are going to help with that development, we're kind of siphoning them off slowly, slowly, slowly. So there are a couple of dilemmas there. One is that you don't want to restrict freedom of movement. That's, one of the basic human rights that is supposed to be enshrined within the post-World War II liberal order. So you can't say, hey, don't come here. I mean, before this, you don't want to say that.
Right.
You do say that, and you're disappearing people right and left. But the idea is that that's something that one should hold kind of sacred, people's ability to move. But then it's exactly the dilemma of India, especially. I mean, India is huge, it's a subcontinent, right? So there's so much variability from state to state. But there are some states where you have one physician in 10,000 people. In the
Mm,
United States, one physician for 3,500 people is considered a shortage.
Wow.
So that it's this question of, well, what is the responsibility of these countries that can provide a higher salary and that can attract these workers? Because the argument, especially from the 1960s, and it continues to be, is, well, this is just about free markets. That if these people want to come, we can't restrict their freedom of movement. And this is just where the market is drawing them and their skill set. There's an alignment between their skill set and their their desire for where they want to be. And that perhaps staying in India, there's a misalignment there.
Mm.
They don't want to be there. And so this is just the way, and the market will eventually just sort itself out
mm,
so that those spaces will get filled in by other kinds of practitioners and things like that. Well, we know that that's not free markets, just that they're not equitable. They're not
mm,
designed to be equitable.
Right.
mhm.
And so what do you do in this kind of instance? How do you think, the pandemic should have reminded us so, intimately
Yeah.
that there's no border is going to save you. No piece of, some political line that you make is going to protect you. This is a global situation. And um, we have to start thinking on this kind of planetary level. How do you try to incentivize to create different kinds of robust infrastructure in country of origin, in all of these places, in the United States, in the places where many of these physicians are coming from, so that when people do make that choice, it's not so detrimental to the larger healthcare infrastructure.
Yeah.
Mm.
So, how do you think about building other kinds of practitioners, community healthcare workers, really establishing this basic local sort of sources of knowledge? How do you think about physicians' assistants and nurses and really utilizing their skills effectively so that there isn't this extreme reliance on the physician? And I think we need to reimagine the distribution of the world, to be honest, because we're in a moment of planetary health. Thinking in these kinds of nationalistic ways is only going to lead to all of us suffering.
Mm. Interestingly enough, among the many different sort of interventions that could be done, let's say politically or maybe by the AMA in terms of its policies, one idea just came to me, just randomly. I don't know what you think about it, but so physicians' assistants, let's say. Um, I used to work I work in an adjacent sort of medical field. And so I know that physician's assistants cannot be made primary care providers for patients. Arguably, there probably are some reasons as to why. But I wonder, it would be interesting if technically that would add more service to the community if they could be allowed to be primary care providers, at least for the basic general medicine
Mhm.
maybe that could be serviced. I don't know. What do you think about that? Yeah.
Yeah, I think that's right. I think we
Yeah.
need to start asking the question is, how do you prevent somebody's first interaction with the healthcare system? how do you make sure it's not the ER?
Hmm.
What are the steps that you can take in order to triage that situation before you're in a state of extreme emergency? So if that means that you have a physician's assistant, you do a first pass at what this situation might be, then maybe you go to somebody with a different kind of training, you get a second opinion, and then you go from there. But going straight from an extreme of not having zero care to, then having some kind of stage 4 cancer,
Right.
I think we have to start thinking about what could have happened in between. What were the spaces of intervention, whether it's even providing kinds of screenings, knowledge, information that people should go and try to find these screenings. What can we do before we get to that point? And so I think there's a whole wealth of knowledge that can be recruited in order to do that kind of work.
Yeah, you know what actually I would love? That gave me another idea. It would be fantastic. So you know how like usually most insurances they'll cover a routine annual visit, physical for let's say a woman OBGYN and
Mhm.
that sort of thing. There should be a routine MRI in my opinion. I think so because for example, you mentioned stage 4 cancer, right? Well, I mean, it's very difficult. I mean, depending on the symptoms that somebody presents with, depending, by the way, the burden of even describing those symptoms, right? I think is even, how should I say this? It's kind of laborsome because, for example, you go to the doctor who, let's say, for every patient encounter, generally speaking, maybe they have a lot of patients scheduled that day, maybe on average spend maybe 10 minutes with that
Mhm.
patient, depending on their specialty. Maybe we're talking maybe more internal medicine or something like that.
Yeah.
Then the burden of the patient to be able to describe what's going on with them, I feel like on one level that's a good thing, and then the doctor kind of hears it. They could kind of come up with maybe how to treat it, maybe do a blood test, that sort of thing. But then there are things that a blood test may not necessarily reveal. And also, depending on how you describe your patients to that your symptoms rather to that doctor, they may then give you a different kind of diagnosis. Like you may say you have headaches, and okay, they're okay. Headache is the diagnosis, or migraine. And then here's this pain medication or something having to do with your blood pressure, perhaps to assist with that. But how would let's say that person does have like, I don't know, brain cancer or something like that. To get to the stage where you would finally be able to identify that that's, that sort of situation, it would have to get to a very serious place first. I mean, I'm not 100% sure of that, but I imagine that to be the case. So yeah, I guess this just boils down to I would love a routine MRI. I feel like you would identify so many things with that. Yeah.
Go to places like Thailand who do it for so cheap. That's my next work project is on medical tourism. So
Wow.
it's all about this whole, yeah, there is a market for that for sure. But I also do think that the US already spends far more, as you said, per capita than any other country. And part of it is having these extreme technological interventions that sometimes are necessary, but sometimes are not. And
Mhm.
so I think it's also about thinking, well, if we just end up spending more and more and everybody gets an MRI, okay, that is one thing, but already healthcare is, I think the largest GDP percentage in the United States.
Okay.
But how do we bring it actually down before then? Because we don't need it to just be a hyper capitalist thing. I think that it can be something that is much more grounded in people's daily existence in actually that conversation. Yeah, symptoms are totally hard to describe. It's weird to say, I feel dizzy, I feel pain. If you ask my mom what her pains are, I can never figure out what she's trying to say. Sometimes it's
Yeah.
a crunching, sometimes it's a squeezing and all this stuff. But that's the work of the physician. That is their investigative job is to, before you get to all right, let's go to that extreme, intense intervention. How can I triangulate knowing you, having a relationship with you, knowing your medical history? Okay, you have long-term arthritis. This is, these are the likely things that can happen before you get to that place of let me break your bones and give you a new knee. I think
Right.
there's that phrase, which I'm going to totally get wrong because I get all of these kinds of phrases wrong. But if something, no, if you hear hooves, it's
Hoofed
probably a
zebra.
horse,
Yeah,
not a
horse, not a
zebra,
zebra.
right?
Hmm. Yep.
Right. So like let's try to figure out all the horses around us before we get to the place of zebra, because there'll be a lot more of those. And I think there's a lot more spaces of intervention that are possible.
Yeah.
Mm.
And Aram, I also want to pick up on the thread that you mentioned earlier. So we had on your Harvard colleague, Cass Sunstein, on a couple of weeks ago. And so he talked about something called the Matthew effect. And he had his own he went sort of to different avenues on it or about it. But the interesting thing is what the Matthew effect is that essentially the rich get richer, the poor get poorer, right? So if you have a country that's essentially sort of garnering as many physicians as possible, I mean, essentially what's going to happen is you are going to have global inequality. So fundamentally, then what's going to also happen is when you build up enough power, which is also, I think, the point that you kind of make as well, is that when you build up enough power, what happens is inevitably exploitation. Whether that's the initial intention or not kind of doesn't matter, but that is what's happening, right? So, for those of us who've grown up on like films, and TV shows or whatever from like the 80s and 90s, we always remember like that story of that kid who wanted to be a doctor because he wanted to go or she wanted to go to Africa, right? So there was the sense of like, oh, I want to go practice in Africa because that's where, resources are again drained. And that's essentially where people need the most help. And now you're sort of seeing that a lot of sort of, physicians or would be physicians in Africa are sort of being brought here as well as, from other countries. So, I mean, the real question is now, and this is such a broad sort of question, and it's such a, I mean, it's so kind of like, kind of loaded, right? But like pretty much like, how do we get there to now be, and now there to be a consideration or a significant consideration of sort of global equality on the one hand, and then also can we even talk about some of the kind of bureaucracy involved in all of this, and even what makes it harder for physicians sort of across the pond, to kind of come here and for them to be able to make a living. So it's a complicated issue, and we could kind of go into it sort of more piecemeal. But the idea is that I think we do need to think of it from a global perspective because it's also not fair that we're draining the countries, obviously resource kind of barren countries. But on the other hand, we also have to understand that exploitation is inevitable in this. If it's capitalism and competition for the sake of capitalism and competition, I mean, essentially, this is going to become a monopoly-like state when it comes to healthcare.
Yeah, and I think we also have to start realizing that a lot of this framing is propaganda kinds of framing. So the physician who's going to go and save Africa, well, it turns out that maternal mortality is better in Rwanda than it is in Mississippi.
Mm.
So we need to start thinking differently about what is actually going on a local level and a county-based level in many of these places within the United States, which have poorer health outcomes than those places in Africa, in India, etc. So I think that there's a part of US domination that is about, well, we are better than. But when you actually look at the nitty-gritty of people's lives and, the South Side of Chicago and in LA and all these things, it's not, their health outcomes are not that significantly different from other places in the world that we consider to be third world, backward, etc. So maybe we need to start having these conversations about why there is even so much local, neighborhood to neighborhood, county to county inequality in the United States, and start to see that actually maybe those places that don't have the most cutting edge precision medicine machines, how are they able to keep people alive in ways that the US can't? Maybe
Mm.
that's the reframing of the question.
Mm.
Gotcha. Okay. And then, yeah, what are sort of the bureaucratic, I guess, sort of stumbling blocks or difficulties in place for foreign-based physicians and actually coming here and treating patients here?
Yeah, I think, those have changed over time, but it boils down to this one question, which is how can we trust that you know the things that you say you're going to know? So, how do you decide that somebody who received their education elsewhere, how do you respect their diploma? What do you do? What kind of things do you say that you actually know the same things as somebody who went to Harvard Medical School? And
Mm.
I think there's all sorts of, racism and difficulties that go into this bureaucratic construction of paperwork, of deciding, nah, this paper is not good enough, this one is good enough. And it's this really complicated translation that has to happen um, over, and I think documents end up being really, really vital in doing that. And so you find this even from state to state, which is where US licensing happens. Some states will ask you, how many books were in the medical library of the school that you were trained in? How many microscopes were there?
Mm.
What is the CV of the professor that you had? Other states won't ask any of those things. So there's also this kind of thing where like, oh, somehow if we ask you enough questions, we will know what your skill set is. But then you have to think like, well, how will you know my skill set if you know about the books? That those aren't exactly, I have a lot of books, but I might be really, really bad at what I do. I might be just good at
True.
really
Mm.
collecting books,
Hmm.
So so it's a really tricky thing to figure out, okay, what is the kind of base level that you decide that somebody who received an education in one place is equivalent to somebody who received it in another place? And I think that has been one of the biggest conundrums. And what happens is this language of competence really gets thrown in as this way of measuring that, which is, a completely loaded racialized term. Of course, people who are from elsewhere are considered less competent than people who are from the United States. And so they have to prove their competence, and bureaucracy and documentation becomes historically has been one route where they're supposed to be able to do that.
Right.
Do you think it's a matter of, so in the book you mentioned brand placement, but in a different sense it's used in the book. Like for example, figures like Deepak Chopra, Sanjay Gupta, like these South Asian celebrities kind of gave a very, very good perception of South Asian providers of doctors, right? And kind of was very good for the community in that sense. Do you think that in terms of maybe how um, foreign medical graduates, like in terms of how they're branded, perhaps it's just a matter of, this is very hard to frame, but like for example, if a doctor comes from Harvard, you say, "Oh,
Mhm.
where'd you go to school?" "Oh, I went to Harvard Medical School." All of a sudden, it's like, and everyone is very
Yeah.
happy, yeah, to hear that. Um, I wonder if there would be a something that could be done in terms of labeling when somebody describes themselves who maybe had their education somewhere else. I couldn't think of what to say. This is the difficult part, but maybe there is a way to sort of circumnavigate that without necessarily having to cite what books you read, as you mentioned, for example.
But maybe the thing to say is we have been a part of the healthcare infrastructure in this country for the last 60 years, over a quarter of the labor force, providing, in some places, 70% or more of the labor force, providing all of this care. And maybe it's time that we just start recognizing how absolutely essential this cohort is to
Mm.
the management of population health. I mean, maybe they don't have to say anything, and that the work that they've been doing for the last 60 years can be recognized for what it is and how vital it has been.
Mm. And I also love, picking up on this. So I also love that you sort of you focus on the fact that it's now kind of not maybe necessarily inevitably, but necessarily that in terms of brand placement, that like it's become sort of its own community or its own sort of entity. And this I think dovetails pretty nicely onto this sort of argument around not necessarily racism, but let's say the construct of race. And there's
Mhm.
on the right this understanding that like, well, aren't we supposed to be beyond that, right? So there's this like with the Coleman Hughes News of the world, there's this kind of, and a bunch of other right wing people, even Bill Maher, I'll throw him in there. So there's this kind of sense of like, but we want an equal society, right? We want a society beyond race. And then you have the more left leaning people who say, well, but that's not real, right? So it's a part of our lives. And sort of the reason why we emphasize race is because you emphasize race. It's not as though we kind of did this. So what I love is that essentially you're saying, in some sense, it's kind of let me see how I can phrase this. It's sort of it's a necessity, but it's also kind of disheartening. But again, it's the necessity part is important, where you have a community of South Asian physicians that have to in some way sort of segregate themselves, but in a way that's sort of helpful to them. So, and the reason why they have to do that is because this is the environment and the setting that they found themselves in. So yes, it would be nice if there were a more equitable society and one that were beyond race. However, we're not there yet. So what I'm saying is that if there was a sort of fusion of these two ideas, which I think for the most part, this is why the right gets criticized, is because the understanding is that they don't really want that, or at least, you know, but hypothetically, again, don't really want that, is because everybody wants that. Everybody wants to get to a point beyond race. But the point is to say, again, why there is a fixation on race is because in the world hasn't overcome it. So, which is why I love that in your work, you essentially focus on South Asian physicians as a lobbying group and as a group more generally, because at the end of the day, there does need to be a sort of band of people that get together and kind of lobby and sort of seek out advocacy for themselves as well.
And I would like to just tag what you just said with a question. It's something I actually had written and prepared. So by the 1980s and 1990s, South Asian physicians, they organized politically. The question is, what strategies did they use to push back against the discrimination, and what made them effective? Yeah.
Mhm. So I think to the point of, yeah, we want to get to a place where we're beyond race, but the thing is we don't all start from the same place. And unless we get to a place where we all start from the same place, where we all have security of food, housing, water, education, so you can't, that is the place where you can start to have the meritocracy argument. But unless you get to that point, you just, it doesn't make, to me, the argument doesn't make any kind of sense.
Mhm.
And so, yeah, so you do have to advocate for oneself, especially when you're in a minority position. And even when you are somebody who is a physician, I think that this is what one of the interesting things for me is, well, you think of physicians, you know, historically, they're the most trusted profession in the United States. All these Pew polls show that they have this prestige, they have this status. But what happens when you just change their racial composition? You know,
Mm.
something changes. And that's where you start to see the ways that racialization operates in this United States, because they've achieved meritocracy, they've achieved that same high status position. But why is it that there's something else? There must be something else that has done, you know, push them into a place where they actually don't have all of those same things, that it's not on par. And so this is where exactly where advocacy has to come in, and where, you know, these physicians were really clever because they understood the fact that they have access to this kind of privileged position because of the trust that comes with being a physician, because of the kind of care that they're providing. And so they have that social status. So
Mm.
how is it that you use that social status? How is it that you use the economic benefits that you've achieved? Because they definitely have, even if they're not getting paid as much as their US counterparts, they're still getting paid significantly well. And so how do you take that and turn it into some kind of organizing and really invest in making sure that your cause is just as prominent? So just as the American Medical Association or pharmaceutical companies have their lobbies, they've really started to emulate these kinds of political structures and say, like, okay, what can we do to make sure that our voices are heard in terms of the legislators that are there? How do we show up so that we can do this work of convincing people that we are absolutely integral to the functioning of this country? So I think they really relied on, you know, ethnic communities have, at least at that time, they had a really robust newspaper infrastructure, for example, and they really took advantage of those kinds of, you know, inter conversations to raise awareness, to
Mm.
create solidarity, even across long distances, and to really push each other to start showing up for these causes. And I think, it I be to think now how much power they have. I think that there was an interesting moment in the 80s where they were just kind of starting to, this first generation has laid the foundation, and now there might be too many, in fact, where it's a little bit more diffuse. But there was this really interesting moment of coalition building between South
Mm,
Asian physicians and Pakistani physicians and Filipino physicians who really all understood that what they're trying to do is in solidarity with one another, and to make sure that there is this awareness about how important they are to the US healthcare
right.
infrastructure.
Right. And also, what I hear you saying, if we were to kind of put this in a nutshell, is fundamentally the construct of race is going to continue to be important as long as the construct of marginalized groups is.
Yeah, absolutely.
Okay. I love that. All right. Great point to end off on.
Yeah.
All right, Alan, questions for Aaron before we go.
Oh, yes. If we wanted to follow you, follow your work, and of course, buy the book, where can we do that?
The book will be out with Johns Hopkins Press on October 14th, and you can find it through their website. And then you can find me at eramalam.com and reach out with any questions. And I would be, yeah, happy to keep the conversation going.
Aaron, thank
Awesome.
you so much for coming on.
This
This
was a
was
pleasure.
excellent and so insightful.
Yeah.
Thank you so much. I really appreciate it. And all the depth and patience that you give these topics is really lovely to be in conversation. Thank you.
Thank
Absolutely. You're very welcome. We'll talk to you soon.
Take care.
Okay. Take
Bye.
care. Bye.
Again, thank you so much for watching. You can follow us at Seize the Moment Podcast on Facebook and on Instagram, and on X, we're at Seize_podcast. Like, subscribe,
Hit
hit
the
the
bell
bell.
on YouTube.
And thank you again so much for watching, and see you next time.